Pain medicine kind of evolved as an offshoot of anesthesia. We were the people that were trained to do epidurals, so naturally we evolved into doing epidurals for back and neck, and now the field's kind of taken off into doing procedures, but also kind of comprehensive pain management for all different types of chronic pain complaints. The important thing is to differentiate chronic pain from acute pain. Acute pain is something that your hand's on a fire. It's an adaptive mechanism in which it causes you to remove your hand from that fire. Chronic pain persists for greater than 1 to 6 months. It's not necessarily designed to help the individual. It can be, pathologic, which is bad. And it's something that doesn't necessarily have a cause that, say for instance like a cancer or a cut. I don't think that there's necessarily a best candidate for pain procedures. I think that there are a number of different pain complaints and pain diagnoses that lend themselves to be more amenable to a specific pain procedure. But I really think it has to do with where the individual's coming from and what they've had done prior to getting here, and what their actual diagnosis is. It's really anyone who wants to explore different options for pain relief, whether it's their first time that they've experienced back pain, neck pain, or there's someone who've kind of been there, done that, and have had every known procedure done to their knee, their back, their leg. There is something that we can offer. There are new things that are coming out every day, from anywhere from minimally invasive spinal procedures to a really exciting new field with regenerative medicine.
A friend of mine recommended you, and I came and saw you, and since I've been here, you've done miracles. I mean, truly speaking.
Good.
It's been great. I just feel 100% better than I did before. This morning, I didn't even think of my pain. That's how much difference it's made. I mean, truly, really. I mean, all kidding aside.
Great.
I didn't even think about it this morning, and that's a rare thing.
Great.
Because I'm usually, with the pain I've had, I'm usually like worried about it. Before I move, I go, oh, geez, I got to get up.
Right.
And I didn't even think of it this morning. It didn't even occur to me. So
yeah,
that's a good thing.
Yeah, when you have chronic pain, you really tend to anticipate it.
Oh, you do.
And it can really grab hold of your life.
Absolutely. It does. It rules your life.
Absolutely.
What pain level am I at right now? And what can I do?
Yeah.
What can I do? That kind of thing. And I had no worries this morning. So that's the first time in a long time. I'll tell you true, I'm 71 years old, and I've had this pain in my back since I was 22 years old. As I just got out of the military, and I've had this pain my whole life. My back has less pain in it now than I can ever remember in all of those years that I suffered with it.
I was in a car accident 2 weeks before my wedding. I had back surgery in 2000 and it just didn't work. I went to another, primary care physician and referred me to the same doctor, not Dr. Q, a different pain management doctor. And all she was wanting to do was keep giving me more drugs. I didn't want that anymore. So went to my primary care, Dr. Susan Kennedy, came back with a referral to Dr. Q, and I've been with him since the beginning when he opened his practice, and he's done wonders for me. He's done wonders for me. I walk, and basically I changed the way I eat, cut out all the sugars, up to my fiber intake, and I also just basically watch how much I eat as well as what I eat and cater around, with things like that. And that's how I lost over 100 pounds. Dr. Q's got me on limited pain medicine. I have the stimulator, as he stated, and together with the injections that are far and few in between, it works.
I was in a fatal car accident. It was bad. I've had chronic pain, headaches, really bad headaches. Headaches got so bad I needed to go to the emergency room often. Couldn't do much with the headaches. Real limited with my knee pain, can't climb a lot of steps, can't travel long distance as far as walking. I haven't worked in many years. I haven't been able to do a lot of things. I've done the Simvix injections numerous amounts of times. I've done I think they did the cortisone shots at the Rothman, and really wasn't getting a whole lot of relief from it. But when Dr. Guger started doing the procedures, I'm actually getting relief. So he's targeting the right areas. I mean, at one time, the headaches were so bad I couldn't do anything for weeks, and since coming to Dr. Guger, it's been reduced more and more. So he don't just, do one procedure and say, well, I don't know what to tell you, take a pill. He tries to do non-invasive treatments, and he tries to do things that's going to be helpful to you, and he listens. If anybody is experiencing a lot of pain, I would expect them to come and give them a try, because Dr. Guger is not only a good person, a good doctor, he really, he cares from his heart.
There's two train of thoughts that our practice has on treating pain. One is, how can we reduce someone's pain right now? And the other is, how can we slow down the development of further pain down the road? In that sort of thought, we really focus ourselves on a field called interventional orthopedics and regenerative medicine. There are special procedures that we do. These include a procedure called platelet-rich plasma, where we can actually draw the patient's blood and under special care, we're able to extract rich growth factors from their blood, and that's re-injected back into those problem areas, and that can slow down the rate of deterioration. We also really believe in viscosupplementation, which is using special medications like Symvisc or Orthovisc, which can provide cushioning and that can really slow down the disease course of joints from developing arthritis. There's also advancements made in using stem cell technology, where we can actually harvest stem cell from patients and again inject them into areas that have deteriorated. We can perform more precise ways of doing the epidurals that's more comforting for the patient and with better results. We're also able to use advanced instruments such as spinal cord stimulation, intrathecal medication pumps. We use radiofrequency ablation, which can help to reduce the pain from arthritis that can last for a long period of time. Our focus has always been to try to reduce healthcare costs, and rather than performing these procedures at places that are very, very expensive for the patient as well as our government, we do these things in our office with very advanced equipment, if not better than those in hospitals and surgery centers, at a cost of 1/10 to 1/20th of that in the hospital and surgery center. And our outcomes are very robust, if not better than those environments.
Acute pain is typically a pain that occurs in a very short time interval setting, and it's usually involved with an injury or an inciting event or factor. For instance, one could have a car accident or a rear-ending injury and develop acute neck pain. And usually the typical course of what that involves is a patient sometimes having some imaging done of their neck, either an X-ray or an MRI. We can evaluate the patient in other ways too, diagnostically. We offer electrodiagnostic evaluations, which are EMG studies. And what those EMG studies can do is they can pinpoint the exact nerve root level where the injury occurred, versus just looking at an MRI and having a static picture in time. We in real time can dynamically, with an EMG, look at a specific nerve root level, and then it gives us better opportunity to appropriately treat the patient. What sets us apart here at the Pennsylvania Pain and Spine Institute is that we don't just look at the MRI image or the X-ray image. We actually spend about a good hour with each new patient directly with the physician, evaluating the whole sort of complex and care needs of each patient, thereby being able to appropriately assess and evaluate what truly is the pain generator in the patient.
The spinal cord stimulator device has been around for a fairly long period of time in terms of its technology. However, over the last really 5 years, we've made such great advances in battery technology that we're able to minimize these devices so that they can be implanted in patients to help with their pain. It's typically done to block pain because, as you know, most of us, unfortunately, at some point in our life will experience chronic back pain or neck pain. When patients have had surgery, such as PJ's case, and she's had some significant low back surgeries with a fair amount of hardware in there, and she was still having fairly debilitating pain. Because of that, rather than sending her for more surgical interventions or more more fusions and things of that sort, we decided to try this this device, which, when put into the correct areas, would be able to produce a different nerve signal that can block her pain nerve signals. And the great thing about this is, unlike injections, which can wear off from time to time, once the device is there, it can work all the time. And it's gotten to the point where we can do very elaborate programming, where patients would have different programs for different activities, different programs for different times of the day, so that if she's walking, she may activate a different set of stimulator parameters that can help more with her leg pain. And the major benefit of the device is that it is such a minimally invasive way to install the device. I had actually personally implanted PJ's device. It was an in and out surgery. It was done on an outpatient basis. It's not done under general anesthesia, so the patients tolerate it very well. They go home just an hour or two after the surgeries. And even patients we've seen patients who are much older, 89 years old, who can't undergo general anesthesia because of the concerns over it, but yet they're able to undergo this procedure that can bring them fairly significant pain relief. With the stimulator in place, instead of feeling pain all the time, when the device is on, she normally will feel less pain, and she could instead feel sort of this massaging sensation. Is that correct, PJ?
That's right.
Yeah.
I feel like a little tingly feeling, which massages it through, and it goes all the way down my legs from my lower back down, and it doesn't bother me at all then. And I usually use it when I go walking the 3.5 miles a day.
Yeah, and I know prior to this device being installed, she was having quite a bit of difficulty with even doing simple things like walking short distances.
Exactly.
So
I couldn't walk very far at all.
And I think the other major advantage of this, a treatment like this versus conventional surgery is that often when we have surgery, there's no trial of the surgery, right? We have surgery and then we pray to God that it turns out well. Whereas with this, with something like this, she actually underwent what's called a 1-week trial of the device, where there were no surgeries done. All we did was we took a very thin needle that went into the back, just like we typically would do with a back injection, but instead of putting medication through the needle, I had actually put this small cable through the needle into her back, and she went home with this for a week to try the device out, and then at the end of the week she gets to tell me, yes, this worked well for me, I like to move forward with the permanent device. That way we'll know that her outcome is going to be favorable, as opposed to surgery where it's fairly uncertain whether surgery can help pain or not. So I think that's the chief advantage of performing this procedure over that. And I think in PJ's case, she's done very well since then. Between, something like this and some of the other minimally invasive advanced procedures that we perform here, she tells me she's been able to lose a fair amount of weight, right?
Over 100 pounds.
Yeah. So, and again, our hopes in pain management is always to manage patients' pains, because unfortunately at some point in our life we may all deal with pain, but we want to do it with less invasive things so that we can improve her functional outcome, her ability to exercise and do all the things that she enjoys, without major surgeries. One of the things I always discuss with patients is when we look at managing pain properly, it's really not just, we don't rely on one thing. We rely on using multiple things. If we just relied on medications, for example, she would be on very high doses and probably would have significant long-term side effects that can really harm her in the future. And if we just did injections, when the injection wore off, her pain would be back. So instead, we utilize multiple modalities here so that we try to cover every single avenue of where her pain is coming from to really help give her the improvement that she needs.
We did the PRP injection on the shoulder. That's the platelet-rich plasma therapy. And how do you think it's been helping you with your exercise activity?
You saw when I first came in, I couldn't lift. I couldn't put my hand behind my back. And my back, I can actually reach back here, put my arm out, this.
Today we're going to repeat that on the shoulder and then in the knee as well, if you wanted to do that.
Yeah.
Yeah, okay, great. So we're going to utilize the ultrasound machine. With the probe, we're able to get into the joint space area. I'm able to take a good look, not only at the structures of the shoulder and the knee, but it also helps guide me to place the medication, which are the platelet cells, in the exact spot that it needs to go into. And we utilize this in the office in this setting. It's just a really great way for us to visualize a joint or a joint space or an area in the body in real time, to know and look at it and know what's going on with it and fix the problem. You know, the nice thing about the PRP is that it's all your own natural cells, you know, so that we're not putting anything foreign into your body that could degrade the existing joint space. You're already at a little bit of a disadvantage because you have the arthritis in the knee. Putting cortisone, as you know, too much of it into a joint space can actually degrade the existing cartilage. As you know, the PRP is the platelet-rich plasma therapy. It's where we take some of your own blood out and we spin it down. We take the nutrient-rich and proliferative cells out called platelets. And what those platelets have shown to do is go into joint spaces, ligament and tendon spaces, which we've done in your chronic tendinopathy or rotator cuff tendinopathy shoulder. And we're basically injecting those good nutrient-rich cells back into that area to help it proliferate and regenerate, lay down some new growth factors, new tissue. All those things help eliminate pain.
There was always constant pain. If I slept on it, it would hurt. And after a week, the pain was gone totally. And now it's just a matter of strengthening it up again because it wasn't used that much for a year. And it really helped a lot.
I was taking 15 oxycodones a day. My liver's in bad shape because of all the medication over the years. I met Dr. Q, and right from the beginning I liked him. And he suggested the morphine pump. It worked great, and the pain is much, I couldn't control better. I still had bad days, but instead of 20 days in bed, I spent maybe 2 days in bed a month.
This is actually a model of what this intrathecal medication pump looks like. And essentially, this is the containment area for the medication. Once the medication is in there, it's pumped through a tiny tube that's connected to the pump, and this tiny tube runs all the way into Joe's back where all those important receptors are for pain medications. And this device is controlled by a programmer like this.
It runs on itself, it's timed. I get an extra dose at 6 a.m., at 4 p.m. to help make dinner, and then 6 p.m. to spend more time with my kids. And then the handheld gives me, if I need it.
Most of the time, the medication that sits in the pump is good for around 3 months or even longer, depending on the type of medication and the concentration of the medication. So he would come to our office for these refills. So instead of going to a pharmacy every month, he would come once every 3 months or so.
I would never go back to narcotics because it's just so up and down, and it's never constant. It's just, you pain, you take a pill, it lasts 10 minutes, and then you're in pain again. The morphine pump, you don't feel any euphoric part of it at all. I just don't feel the pain. There's just things he does that, no one's ever even suggested. I've seen probably 50 different doctors, you know, from rheumatologists, orthopedists to, you know, pain doctors, and you know, it's just, this is the greatest place on earth. I mean, how do you thank somebody for giving you quality time with your kids and your wife?
I went to a different pain management doctor, and it was amazing that I could function. I was on such high doses of drugs, and I didn't want that anymore. I tried acupuncture, but it wasn't for me anymore. So I weaned off the medicine, went a couple months, about 6 months without any medicine, couldn't take the pain anymore. So went to my primary care, Dr. Susan Kennedy, came back with a referral to Dr. Q, and I've been with him since the beginning when he opened his practice, and he's done wonders for me. Dr. Q has got me on limited pain medicine. I have the stimulator, and together with the injections that are far and few in between, it works. It's a big immediate change, and it feels really good to have that pain that you've got that's going down your leg go away, and to know you're not going to have that for a while.
Now that PJ is doing better in terms of her overall pain, you know, one of the things that I always get concerned about in patients who've had fairly significant surgery in the spine, whether it's in the neck or the back or the mid-back, is that there's this buildup of scar tissue in those areas. So we really believe in a special procedure called a single-day percutaneous adhesiolysis procedure. Essentially what it involves is, rather than going back into her spine to try to get rid of scar tissue, because again, anytime we have surgery, whether it's in our abdomen, whether it's in our back, our body forms scar tissue along where the surgical sites are. The unfortunate thing with back surgery is that we have many, many important nerves in the low back that run down into the legs, that run into the back, that controls pain sensation. So when scar tissue builds up in those areas, they create a lot of pressure on those nerves, and they can cause the nerves to be inflamed and cause pain. And so with this procedure, our goals are to use a very minimally invasive technique of using a very thin needle and a catheter that goes through the very base of the spine. Because again, with PJ's spine, you know, she has a fair amount of hardware in those areas that would be very difficult for normal techniques to put this needle through. But by going through the very base of the spine, I'm still able to do this procedure without creating any additional discomfort for her. So by, again, inserting this very thin needle up into where her previous surgical areas were and injecting special medications, those medications are able to dissolve some of the scar tissue and take the pressure off her nerves. And I think it's been working well for her.
Yes.
Typically, I would repeat them every so often when the pain starts to get worse again. Because again, you know, we want to keep her going and continue to, you know, her role to lose weight. Although at this point, I don't think you need to lose much weight. So.
Only about 9 more pounds.
That's terrific. Yeah.
Can I go walking my 3.5 tonight?
Of course,
Good.
Of course, and that's and that's one of the great things of our procedures is we typically don't restrict the patients afterwards, and so that they're able to really continue their lives right after the procedure.